Okay. Welcome everyone for the next episode of H2S Academics. Today, Dr. Niva, he's a fellow of ours from Nepal. He finished his MS in 2017. He'll be discussing about Walkman's ischemic contracture, which is fairly common in this part of the world. So, Dr. Niva, we can start. Can you share your
Yes,
screen?
sir. Yes, sir. Okay. Shall I start now, sir?
Yes, you can start. Yeah.
Yes, you can start. Yes.
Yes. Good evening, sirs and my colleagues. Today I'm going to talk about volcanic ischemic contracture. So this was first described by a German surgeon, Richard von Wolfman, in 1881, and he described it as an irreversible muscle ischemia causing necrosis of the muscle and nerve damage, which led to contracture of the wrist, forearm, wrist, and hand. And he attributed this ischemia to tight compression bandaging alone. It was only in 1909 that Hildebrand first coined the term Volkmann ischemic contracture. Even though Volkmann had attributed this condition to tight bandaging, in 1909 Thomas reported 107 cases in which ischemia occurred without the use of splints or bandages. In 1914, Murphy reported that increased internal pressure in deep compartments of forearm and effusion in muscles resulted in ischemia, which later caused contracture. And it was in 1928 that Jones concluded that contraction could be caused by pressure from within, from without, or both. That is, uh, contraction due to increased pressure or tight bandaging, or both of these conditions. There are many etiology causes for Volkmann ischemic contracture, but uh, the basic of this is any cause that might end up in compartment syndrome, which is unrecognized or inadequately treated, can be taken as a cause for Volkmann ischemic contracture. Regarding the anatomy, at the entrance of the flexor compartment of forearm, there is a structure called the lacetus fibrosis, which fans medially from biceps tendon. And beneath this lacetus fibrosis lies the brachial artery and medial nerve, which pass to enter the flexor compartment. So any condition that causes increased pressure at this region or edema of the muscles around this region causes the lacetus fibrosis to compress the brachial artery and medial nerve. So this is one of the major reasons why medial nerve is much more commonly affected as compared to the ulnar nerve or the radial nerve. The pathogenesis entirely depends upon the increased intercompartmental pressure, which can be either due to increased compartmental content or decreased compartmental size. Either of these lead to decreased tissue perfusion, which causes increase in capillary permeability, which leads to increased exudation, and that again leads back to increased compartmental content. So this is a vicious cycle, and will continue to do so until we release the compartment or there is death of the muscles and the nerves in that compartment. So the effect that this has on the muscles is that there is irreversible changes in muscles after 4 hours, uh, which leads to muscle necrosis. Then there is fibroblastic proliferation, which brings fibrotic changes in the necrotic muscles. The fibrous tissues then shrink in both longitudinal and horizontal plane. That leads to contracture. Uh, the fibrotic tissues take around 6 months to 1 year for maturation. So we can say that the deformities they continue to increase or progress till 6 months to 1 year. And this is important because if you are treating a patient conservatively, we have to make sure that the patient is wearing the splints for 6 months to 1 year until we notice that the deformity is not progressing. And in case of children, the splinting has to be done until skeletal maturity. In nerves, the irreversible changes occur 8 hours after the initial ischemia, and the nerves are affected mainly by two mechanisms. The first is vascular, in which it is caused by the initial primary insult, and secondly, it is caused by the diminished circulation due to the surrounding fibrosis. The second factor that affects the nerves is the fibrosis itself that compresses the nerves and the inability of the nerve to glide in a fibrotic tissue bed. The deeper muscles of the forearm, especially the FTP of the middle and ring finger, are most vulnerable. The extensor muscles may be involved in severe cases, but in the other cases, they are not much involved. And maximum damage to the muscle occurs in the middle of the muscle belly, and it has been well explained by the sudden ellipsoid infarct concept. And with progressive damage, the nerve becomes markedly thin and atrophied. And as discussed again, median nerve is always more affected than the ulnar nerve. When a patient presents to the hospital, the patient presents in either one of the three stages, that is the initial stage or the vascular crisis, where the patient has compartment syndrome, and until and unless we don't intervene and adequately treat compartment syndrome, it progresses to the stage of progressive fibrosis and paralysis. Once paralysis sets in, then it is called the stage of established contracture. There is Volkmann ischemic contracture. Uh, Among many classifications that are used to classify VIC, Holden classification, SUSE, and Zanconi classification are the popular ones. Holden classification is based on the site of vascular compression. In type 1, the compression is proximal to the site of ischemia, like in supracondylar fracture, whereas in type 2, there is direct localized compression to the distal segment, which causes increased local compartmental pressure, like in a case where a tight bandage has been applied to a forearm. SUSE classification is the most commonly used classification as it helps in planning our management as well. It has been divided into three types: mild, moderate, and severe. In mild, there is localized contracture that usually involves only the deep flexor compartment, that is mainly the FTP of the long and ring fingers, and it has very little or no nerve involvement. In moderate, almost all of the FDP and FPL are affected with partial involvement of the FDS. The neurological impairment is present, and like discussed earlier, median nerve is more affected. In case of severe, all of the flexor compartment muscles are affected with varying involvement of the extensor compartment muscle. There is severe neurologic deficits, which include sensory defect and intrinsic dysfunction. Zanconi classification is based on degree of involvement of intrinsic muscles of the hand. In all of type 1 to type 4, it involves contraction of the forearm muscles, whereas in type 1, the intrinsic muscles are normal. Type 2, there is paralysis of intrinsic muscles. And in type 3, there is contraction of the intrinsic muscles. Type 4 is a combination of all. The management, though there are various classifications for VIC, the management is always it's not so easy as it is based upon the individual, and it mainly depends upon the involvement of each of the components of forearm, mainly the skin, bones, tendons, joints, nerves, and vessels. So a combination of such classification with Holland's classification is considered to be a systematic guide for management. Regarding the timing of intervention, Seddon advocated that a delay of 3 months is necessary, whereas Sush is preferred to delay for 6 months in order to allow the overlying skin to settle and for the spontaneous recovery to reach a plateau. It is mainly preferred in cases with reasonable hand function, as early intervention is more preferred in case of severe cases in order to prevent thinning of nerves and further joint stiffness. The studies have shown that prompt neurolysis and excision of fibrotic tissue have shown to relieve severe neuralgic pain. So for this reason also, in case of patient with severe contracture, prompt surgery is preferred. Regarding the treatment options, there are conservative treatment options and surgical treatment. In conservative, we can treat the patient with splinting, which might be static progressive or a combination of dynamic and static splinting, along with passive mobilization of the joints. In surgery, there are various surgical techniques that can be done. I shall be explaining in detail about these. So, in surgical treatment, if a patient presents with mild type of symptoms, then the patient can simply be treated with passive stretching exercises and splinting. If few deep flexor muscles are involved with no sensory or intrinsic loss, then fractional release can be done. But the downside of fractional release is that we can increase the length only by 1 centimeter. If more than that length is required, then we have to do a Z lengthening plastic, uh, by which we can gain a length of 2.5 centimeter. But again, this also has a big disadvantage as it further weakens the already weak muscles. In moderate type, uh, if the muscle mass is satisfactory and there is adequate continuity of the muscle, we can treat the patient by genolysis, fractional or Z lengthening, and if required, neurolysis. If the patient has good finger flexion but diffuse contraction, in these cases, a proximal muscle slide or max pace procedure has to be done. If the patient comes with non-viable flexion muscles, but uh, if there is no involvement of the extensor compartment, then tendons from the extensor compartment can be used can be used as tendon transfer, and we can do ECR to FTP, break radialis to FPL to regain functions, flexor, fle flexion functions of the fingers. If the flexor muscle mass are non-viable and the extensor compartment is also involved, then we cannot transfer muscles from the extensor compartment. So in these cases, microvascular free functioning muscle transfer has to be done, and gracilis is the muscle of choice. In severe cases, nerve reconstruction or nerve graft is also necessary, and in these cases, uh, the necrotic nerve has to be resected until the fascicles appear healthy. And the ideal nerve for nerve graft is the pseudo nerve. In severe type of cases, these are best treated with free functional muscle transfer, as the all of the flexor and the extensor muscles are involved. So again, the gracilis muscle is the ideal muscle, and nerve transfers have to be done to address serious sensory and motor loss. And if after transferring the muscle or the nerve, if we find that the length of the muscle or the nerve is not adequate, we might have to do bone shortening procedures or proximal rope carpectomy. Now, I'm going to describe briefly about the surgical techniques. In fractional lengthening, after we give incision on the molar aspect and the muscles are exposed, we give incision on the muscular tendinous junction. But we have to be careful that the incision is only on the tendinous fibers and not on the underlying muscles. So we can give two incisions on the FCR, FCU, FTS, FPL, FDP, and the parietal teres muscles, as these are relatively a broader muscles. And when we give two incisions, the distal incision has to be oblique and the proximal transverse, and the distance between the two incisions should be 1.5 centimeter. Uh, Whereas in palmaris longus and flexor distal muscles, we can give only a single transverse incision. And as if the fractional lengthening is not adequate, we have to do a Z plastic lengthening. For this, we have to uh, the the medial aspect of the proximal tendon is attached to the lateral aspect of the distal tendon. By this, we can gain length, uh, and then, like I had explained earlier, if a patient has good movement of the good flexion of the fingers, but he has a diffuse contracture, then a flexor muscle slide has to be done. So in this case, we have to give incision on the medial aspect. Uh, After that, we first have to identify and isolate the ulnar nerve and make sure that the MCL and joint capsule are well preserved. After that, we release the origin of the flexor muscles, the flexor mass. And as we do this, we have to frequently passively extend the wrist and the fingers in order to identify the structures that remain tight, so that we can, after identifying these structures, we can release those tissues as well. And also it helps to know when the release has been complete. So if we gain full passive wrist and finger extension, then we know that a complete release has been achieved. And if necessary, a carpal tunnel release has to be done if the initial slide fails, and this has to be done through a different incision. And if there is a residual pronation contracture, we have to release the frontal quadratus from the ulnar origin and the volar or dorsal ulnar joint capsule as well. Now, to regain finger flexion in the patients, we can do ECRL transfer to FTP. For this, we detach the ECRL from the base of the second metacarpal and then redirect them subcutaneously along the radial border to the volar side and suture them to the FTP tendon. But before that, the FTP tendons are plicated in appropriate tension to achieve a normal cascade of the fingers. Then the ECRL is woven by passing through each slip of the FTP in oblique manner with a non-absorbable suture, and post-surgery, a cast is applied with the wrist in neutral and fingers in semi-flexed position in order to keep the ECRL in full tension. Now, to regain the flexion of the IP joint of thumb, we can do a brachioradialis transfer to the FPL. And in this also, it is similar to ECRL, where we release the brachioradialis, reroute them subcutaneously to the volar aspect, and then suture it to the FPL. Now, for opposition of thumb, though there are various techniques that can be done for open plastic. But in a patient with VIC, since the all of the flexor muscles are gone, we don't have any other choice besides the extensor muscle. And for this, the EIP is the most ideal muscle. For this, the EIP is removed along with a small hood uh, from the extensor retinaculum, from the extensor hood, and then it is transferred through subcutaneous tunnel over the ECU around the distal ulna, which acts as a pulley. It is then incision is then made over the thinner eminence, and it is pulled subcutaneously distally to the thinner eminence, where it is sutured to APB. By doing this, we can achieve opposition of the thumb. Now, in severe cases where neither of the previously described techniques can be done, we have to go for a free functional muscle transfer. This is mainly done for restoration of the extrinsic flexor muscle functions. And as I said earlier, the gracilis is the ideal muscle as the size matches to that of the forearm, and it has good excursion and power. Now, before doing a free functional muscle transfer, we have to make sure that all fixed contractures and tendon adhesions distal to the pliant site are released. The median and ulnar nerve, if necros are constricted, have to be excised, and pseudo nerve has to be done prior to the muscle transfer. And if both the median and ulnar nerves are involved, then priority should be given to median nerve because it provides radial sided sensation for pinch, and also there is higher likelihood of recovery in both sensory and motor function in the median nerve as compared to the ulnar. So to To harvest the gracilis, we put the patient in a supine frog-like position. A two-team approach is preferred. The recipient site is prepared before the donor muscle is harvested. And it is preferred that an intraoperative frozen section is done to identify healthy fascicles of the muscle, the recipient motor nerve. Then an axis of this section is marked from pubic tubercle to the insertion of vas anterioris. Distal incident is made and gracilis is identified between sartorius and semiteniosus. The dissection is done from distal to proximal and from posterior to anterior. So after the harvest is after the graft is harvested, then when we are transferring the muscle, we have to do an artery and venous anastomosis first, and then allow the muscle to perfuse for at least 10 minutes. After that, a new muscle origin is made at the medial epicondyle. The gracilis tendon is weaved to the FTP and FPL. The repair is performed with the wrist and fingers in flexion to minimize tension. The FPL function is reconstructed with a tendon transfer, ECRL or VR. But if neither of them are available, then a separate neuromuscular territory of the gracilis can be used to create a separate functional muscle, but this requires two motor donor neurons. And at last, neurography is completed, not earlier than that. So the take-home message is this, that failure to address severe muscle necrosis with wide external necrotic fibrotic muscles may result in nerve ischemia and contracture. It is always best if we excise the necrotic of muscles or fibrotic muscles earlier, as this will limit scarring and ischemia of nerves. Progressive or recurrent deformity during growth might occur regardless of treatment. So night splinting should be continued throughout skeletal maturity. The flexor prolator slide in incomplete correction at the time of surgery will not improve post-operatively with therapy. So we have to make sure that when we are doing the surgery itself, we gain proper function, we gain proper movement of the joints. And when we are doing a free functional muscle transfer, we have to make sure that the ischemia time should not prolong beyond 2 hours, because if it crosses 2 hours benchmark, then even if the muscle will survive, it will have very poor function, and it will ultimately lead to second muscle transfer. So it has to be done prior to the 2 hour window. And aggressive therapy immediately after surgery can lead to rupture of muscle fibers. So gentle rehabilitation is required for the first 6 months following the free functional muscle transfer. Thank you.
Thank you, Niva. Really good presentation. Can you stop sharing your screen?
Yes, sir.
So, Hiba, any
Yes.
questions?
Actually, I like the presentation too much. It reminded me that I have a series of 25 patients with moderate Volkmann ischemic contraction treated with, we just do like Z blast lengthening with good result. But the issue was the patient expectation in all these cases. If the patient has very big expectations, the result will not be too much. And my question was with this muscle transfer, because I don't know anything about the free muscle transfer. So with the gracilis, we put it on like the flexor origin, and then we just reconnect all the other muscles fibers, or what exactly, how it will function? I can't imagine it, how it will work.
Okay. Niva, you want to answer?
So I will try.
Okay. I'll take it for you. See, it is a free muscle, free functioning muscle. So the gracilis is taken with the neurovascular bundle and the nerve. So now you are taking a whole motor unit with it. So you are taking proximal
with the
end
nerve itself, with
the neurovascular nerve and the vessel.
Okay.
Profunda. So what you attach one end to the bone, that becomes the origin. Muscle part muscular part to the bone, proximal to the proximal. The distal tendinous part is connected to the tendon. So tendons are connected to the distal end of the tendon of the muscle.
Okay.
So only
we
issue,
take it like
the biggest
the
issue is
flexor
you have to
tendon
take it with,
origin.
you have to take it with the skin, and
Oh.
then now because it is different from the tendon transfer, because first muscle has to regenerate, then only once it regenerates, the nerve supply comes, then it becomes like a whole muscle unit.
Okay.
And because gracile is bulky, many times you have to take it with the skin. Otherwise you have to first use tissue expander. Once you use tissue expander, you can take extra skin, then you can transfer, because usually in BIC the skin is also contracted. And gracilis is a bulky muscle from the thigh. It is coming to the already contracted forearm. So you have to choose about your skin also, closure also.
Yes.
Yeah.
Okay. I get it now.
Akram, you want to add anything?
So it was a very good presentation, Dr. Niva. Only thing, one doubt. So how would you explain the release of carpal tunnel improving the flexion contracture? Dr. Niva?
Yes, sir. So, that I also don't have much idea, but it was written that if we do not get adequate flexion
Can I
after doing
answer for the Niva?
Yes, sir. Yes, sir.
See, the carpal tunnel, the transverse carpal ligament, it acts as a pulley. So what it does, it is releasing. So maybe you get some amount of flexion at the wrist, and tendon takes a shorter route by bowstringing, and you can get the extension. Other thing is when you're done a Z-plasty in the tendons, when you're extending the repaired part of the from the distal forearm, they can come and get stuck in that carpal tunnel. So you are making an adequate space when you are doing a passive extension or extension of the muscles. It comes really distal. Akram, you
Dr.
agree?
Niva? Yeah, do agree. I just wanted to hear it from you, but yes, this is the correct explanation of why a carpal tunnel release to allow tendons to distalize or to come to the surface and allow tendons to bowstring so that there is relative lengthening of the tissue.
Okay.
Welcome, Jyoti. Jyoti. Hi, Jyoti.
Yes, sir. Good evening, sir.
Yeah, you want to ask something?
No, sir. No doubt.
So it is always, we should not go for the surgery just as soon as we see the patient. We should always try to be conservative. You've seen like passive stretching, turnbuckle splint, dynamic splints. It should not be as soon as we see, we go for the surgery. Because many times if you're going too early, when you increase the scarring, and which is not good for the muscles they scar more. Yes, surgery can also add to the scarring and fibrosis. Pallav, any questions?
No, sir.
So
May I ask another question?
yeah.
Okay, so for the finger casket, I know I have to go and read about this, but with the Volkmann ischemic contraction, if all the flexor tendons are ischemic, so how can I determine? Because usually with the casket, I compare it with the other fingers. So if all of them are ischemic, I don't know how can I just know what is the casket of the fingers to do the tensioning of the muscle on it.
Akram, you want to answer?
Yes, you have to maintain a normal cascade that a radial finger has to be slightly less flexed than an ulnar finger. So the key is not to maintain the normal cascade of the hand.
Okay. So by doing that, the ulnar finger should be more flexed than the
More flex
radial
than a
finger.
radial digit. Yes. So
Okay.
at the end point of your fixation, end point of your release, or end point of your G lengthening, you should be able to maintain a normal cascade in which the radial finger is less flex, or you can say that ulnar flexor finger is more flex than the adjacent radial finger.
Okay. And there is no like specific angles for that, or it just like
Usually,
this should be more flexed
usually,
than the other one.
yeah, it just should be like more flex. You should maintain
Okay.
that.
Like,
Okay.
yeah, normal cascade, like it's in the normal cascade. So if you want to see the how much release you have done, you
Uh-huh.
should be able to extend in a neutral position of the wrist. You should be able to extend.
Okay.
Don't go for this, because then what happens? The weakening is more. So more lengthening you do, it's a better release. But somewhere in the between, more you release or more you lengthen,
You
more
weaken the
power you
muscle.
lose. More power you lose. So it
Oh,
has to be towards the neutral, somewhere in middle.
okay. I get it.
Sir, can I ask a question, sir?
Yeah.
Sir, there were two conflicting sort of statements in the presentation that Seddon was advising to go for surgical management or any management after 3 months of development of VIC, and Surge was advising to go after 6 months of developing of VIC. So, sir, what should be the in current scenario?
Okay.
What should be the ideal
Uh,
time?
okay. Okay. The things are different completely too. See, if you do a early release, it's good for the nerves, but bad for the muscles. You got it? Because there's you go early, so nerves are released, so the neural damage is less, but you're damaging muscles. So you have to choose between what is affected more. But
Okay.
Sedin was came later. Sedin, this thing coming later. Uh, it's not only release. Before release, you must do all your stretching exercises and splinting, etc. Because you do the release, you cause more damage to the muscles. Muscles which have already gone ischemia, and you cut open, you release it, then you're causing more scarring. So then damage is, in fact, more damage is inflicted. So end result might not be good, because it's not only correcting deformity or correcting the contracture. You have to get the power also.
Okay.
Akram, you want to add anything?
Sir, it is just about the school of thought. The one person is following that early intervention, but definitely you are right in that if you want to control the fibrosis, you go in early. If you want to control the fibrosis around the muscle, we go early inside. If we want to have good strength in the muscle, it depends. We should wait for fibrosis to settle.
See, if nerves are affected more, that's what I understand. If nerves are there, if you're going early, you may be saving nerves, but you are losing on muscles. You're causing more scarring in the muscle. So I think there's a good article, Seddon article you quoted, Niva?
Yes, sir.
You quoted that article because I sent you that article by the Seddon,
Ye-
VAC, the review article.
Yes, sir.
So here in that article, he discusses what happens if we go for an early intervention and what happens if we go for a late intervention. I think we'll share that article in the group. In the WhatsApp group, we'll share that article.
Sir, can I ask a question, sir?
Yeah, Jyoti.
Sir, during conservative management with splinting, can we use some medications for treatment, sir? Like, sir, indomethacin or any NSAIDs, which has any.
Hey, indomethacin, I don't know. It's more like a NSAID. There are other better NSAIDs you can give.
Okay, sir.
Elevation, the physical things are better because it's a very long process. It's not a 1 day, 2 hours, like it's not a compartment syndrome. You can say it is a chronic compartment syndrome,
Okay, sir.
which is the muscles are dead. Now they are regenerating with the scar tissue. So it is a ischemia which has not gone up to the gangrene, but it has damaged the muscles.
Okay, sir.
So I don't know. Some people would say vitamin B12 and vitamin C, but I don't know. We can look at the study. Niva, why don't we see the literature, medical management? Did you cover that medical management?
No, sir, I did not go.
Because see, you can
You
prevent it,
can
but once
see.
VIC has happened, it is a process which continues because muscles are dead. Dead muscles are myoblasts are replaced by the fibroblast.
Okay, sir.
Okay, so
Yes.
the ischemia has already happened. Then BIC comes afterwards. When prevention, it is good that when swelling is occurring or in acute stage, you can give NSAIDs and other things. But once it is done, then it has to be replaced by the fibroblast. Akram, you want to say anything?
Actually, I don't think there is a role of any medical management in an established VIC.
Yeah, that's what. Once muscles are dead, they'll be replaced by fibroblast.
Okay.
Except for maybe somebody who attempts only neurolysis, you can start them on vitamin B12 or any neurotonic that you want to. But I think their literature does not support, as far as I know, we'll go through it again. As far as I know, there is no recommendation in terms of medical management. Physical therapy, splinting, night splints, these are all things which have been discussed at large in literature.
Okay, so thank you, sir.
So if you're done with the
Anyone
question,
else?
any more questions? Niva, whatever articles you have collected, why don't you share in the group? It will become
Sure, sir.
a kind of a collective library kind of a thing, so that whoever is
Yes,
interested
sir.
can go through those articles. Because articles, they have more fine prints and more things, what studies they have done and what variables they have taken.
Yes.
But I must say it was a very good presentation, and